Hi, everyone. This is David Lewis, and this podcast will be on obstructive versus restrictive lung disease. So before we start, I'll quickly go over the learning objectives. The first one is just to understand the process of taking a complete history and physical exam relating to pulmonary disease. So if you listen to the prior podcast on how to take a H&P, this should be pretty simple, but I'll try to focus in on lung disease. The second learning objective is to understand pulmonary function tests, also known as PFTs, and how they relate to specific diseases. To determine the severity of asthma based on symptoms and signs. And lastly, to understand the treatments involved with COPD and asthma. So what exactly do obstructive and restrictive lung disease mean in a clinical setting? So Aditya talked about kind of the pathology behind some of these, but as a clinician, what you want to do is first think about, is this most likely an obstructive or restrictive lung disease? And in order to do that, you kind of have to know the diseases, and you're able to make a differential list based off of that. So let's start with some obstructive diseases. First off, what is obstructive? You should already know this by now. It's just simply air trapping in the lungs due to decreased elasticity, right? So a decrease in the lungs to collapse on themselves and allow for air to be expelled. So obstructive diseases include asthma, which you all know about, COPD, and bronchiectasis. So COPD is broken down into chronic bronchitis and emphysema. I'll go into the specifics of these a little later, but those are the three main big obstructive diseases. Restrictive, there's a lot. The pathology with this is just the inability to bring air into the lungs as opposed to exhale air out of the lungs. So in this case, instead of it being elasticity, now it's compliance. Because compliance, if you remember from physiology, is the ability of the lungs to expand. It's not only just the lungs, but compliance in general means how much something can expand. So diseases that fall under this restrictive category include idiopathic pulmonary fibrosis. There's different pneumoconioses, which are just restrictive lung diseases related to occupational exposure to things that you can inhale that cause lung disease. So asbestos, silica, beryllium, or coal. So that's relatively common around here. Drug-induced pulmonary fibrosis, there's chemotherapeutics like bleomycin. There's methotrexate, which we talked about in the rheumatoid arthritis lecture, that can cause pulmonary fibrosis. There's a drug used for cardiac arrhythmias called amiodarone that can cause pulmonary fibrosis. So there's a bunch of drugs that when you go through a patient's history and you see their med list, you want to consider these. Radiation, if someone's having radiation through whatever the case may be, having multiple CAT scans or x-rays, you want to consider this as a possible cause. There's extrinsic causes, so diseases that cause a restrictive lung disease pattern that isn't intrinsic to the lung parenchyma. So in this case, myasthenia gravis, ALS, kyphoscoliosis, which is the curvature of the spine that would prevent full expansion of the diaphragm, allowing air into the lungs, and pain, which would prevent a person from breathing normally. Last, you can have a fixed upper airway obstruction. So this presents differently than obstructive or restrictive, and you want to think of something like foreign body aspiration that would prevent inspiration and expiration. So they have components of both obstructive and restrictive. The other one is anaphylaxis from, if you remember, that would be like a type 1 hypersensitivity response leading to bronchoconstriction and severe vasodilation leading to hypotension. Okay, so when taking a history and physical, what are you looking for when it comes to lung disease? Well, you want to know if they have a history of any heart or lung disease. You want to know if they're a smoker. Not just that, but you want to ask how many per day, how many years has it been since you started, and are you currently smoking? A lot of people will say, no, I quit, and then you ask how long, you said, 2 days ago when I was in the hospital. So that's not really quitting. The other thing you want to think about is if a person has been smoking for 15 years and smokes 1 pack a day, then that's a 15-year history. If they smoke 2 packs a day, now it's a 30-pack history. So you have to kind of do the calculation in your head, because if they do 2 or 3 packs a day, then that's a lot more than just the amount of years that they've been smoking. You want to know if they're on any medications or chemo drugs that I mentioned earlier. Occupation, do they have exposure to silica or asbestos? Quality of life or changes to lifestyle, has their breathing affected their ability to walk up a flight of stairs or sleep at night? These are all very important hints that you'll learn about throughout medical school that'll help point you in the right direction. Some of the symptoms you can ask about: are they coughing? Are they bringing up any sputum? Hemoptysis means coughing up blood, so that's something like pneumonia or tuberculosis or lung cancer. Dyspnea, which just means shortness of breath. Are they having this at rest or on exertion? Orthopnea means that you get short of breath when you lie down. Paroxysmal nocturnal dyspnea, or PND, means that the person wakes up in the middle of the night gasping for air. They feel like they need to open a window. And these are all very classic symptoms, but you actually hear it out in the offices when talking to patients. Are they wheezing? Do they have any rashes, peripheral edema? Are their legs swelling? Do they have any JVD in their neck? Are they having any fevers, weight loss, night sweats, or chills? These are all B-type constitutional symptoms, which point you more towards some type of cancer or TB or something like that. Okay, so now you're done with the history and you're going to perform a physical exam on the patient. First thing you want to do, I'm going to focus just on the pulmonary aspect. You want to inspect the chest and the neck. Are they using accessory muscles like the scalenes? Is there any trauma to the neck or the chest? Is there bruising? A flail chest means that on inspiration, instead of the chest wall rising, a piece of the chest actually does the opposite. So that's a sign of trauma and multiple rib fractures. You want to calculate the respiratory rate. This will either be given to you by the nurses, but you can also verify that it's correct, or there might be a change, so you can calculate that just by counting for a minute. You can listen to the lungs. There are a lot of different sounds that are kind of confusing. There's some great websites that if you want to hear what these sound like. The big ones, vesicular is a normal breath sound. Wheezing you hear with asthma or some types of COPD. Rales just means crackles. Then there's rhonchi, which are low-pitched wheezes. You can have higher-pitched wheezing. Bronchial breath sounds, pleural rubs, and bronchovesicular. So if you want to go on YouTube or whatever website you can find what these sound like. You want to percuss. You want to know if the sound has changed based on lung pathology, if they have a pleural effusion, or if a lung has collapsed, which is known as a pneumothorax. That'll change how they sound when you percuss the lungs. Tactile phremonus, egophony, these are all different physical exam findings that can help lead you in the right direction, that all have to do with how they sound when you place your hands on the lungs, or if you auscultate, whatever the case may be. The last thing you want to do is look for signs of right heart failure. JVD, meaning is there any jugular venous distension. Hepatojugular reflux means you press on the right upper quadrant near the liver, and this will actually produce JVD. So even though you're pressing on the abdomen, you're paying attention to the neck. Hepatomegaly just means enlargement of the liver. Pitting edema of the lower extremities. When you press, does it take a while for the skin to pop back up to its normal shape and smoothness? Okay, so now let's focus specifically on COPD. Like I said earlier, that's broken down into chronic bronchitis and emphysema. One of the little hints to think of chronic bronchitis is blue bloaters, and this is because they're normally overweight and cyanotic. So the other symptoms that you want to pay attention for, or history, is are they a smoker? And then I said overweight, I said cyanotic. The diagnostic criteria requires that they have had a productive cough for over 3 months during the past 2 years. If they have not had that, then they most likely do not have COPD. You can still confirm that by doing pulmonary function tests, which I'll talk about in a little, but those symptoms over that time period is required. The other thing is you want to look at the respiratory rate, like I said, that'll either be normal or only slightly elevated. Now that differs from emphysema, also known as pink puffers, and they're pink because they're not cyanotic, so they're not blue, and they're puffers because of how they breathe. All right, so let's start at the top though. These patients are also smokers. They're thin as opposed to someone with chronic bronchitis who is usually overweight. They are not cyanotic or acyanotic. They lean forward when they breathe because it helps get air out of their lungs. They're barrel-chested. Barrel-chested is pretty general for COPD in general, but it's seen more in emphysema. So that just means there's an increased AP diameter, or anterior-posterior diameter. So the lungs are chronically expanded. And you can see that by just observing the patient, and it's also visible on a lateral chest x-ray. These patients are usually more distressed, so you see the accessory muscles that I talked about before, more so than in a patient with bronchitis, chronic bronchitis, I should say. Tachypnic, meaning their respiratory rate is fast. The easiest way to think about it is that the rate is over 20 breaths per minute. They'll have prolonged expiration, and they breathe through pursed lips, and this helps to allow for air to leave the lungs, but not in a way that would collapse the lungs. So you can look through your physiology notes if you want to review kind of the physiology behind that. And lastly, if you see these symptoms in a young patient and they're not a smoker, then they can have something called alpha-1 antitrypsin deficiency. And this is also associated with a family history of lung disease at an early age, and they usually have liver involvement as well. Okay, so that involves being deficient in an enzyme that would normally help to prevent the lungs from expanding too much. So without that, there's proteases that kind of destroy the lung tissue. All right. So now I'm going to go back and talk about asthma. Okay, so this is another type of obstructive disease. There's a triad that you normally can think about with the pathology. So there's a hyperresponsiveness of the airways, there's inflammation of the airways, and these symptoms are reversible. And this is a hint that it's asthma and not COPD, because COPD is not reversible. Symptoms are a little different as well. You usually have a non-productive cough, meaning that there's no mucus. You get chest tightness, wheezing, shortness of breath, and you don't have to have all these symptoms. Sometimes the only symptoms that you have is a non-productive cough, and that cough can happen at night. There's two real coughs at night that you think about. One is asthma, the other one is acid reflux, or GERD. So next is, how do you diagnose? Well, you take the history and the symptoms, you do a physical exam, but in order to diagnose, you have to do pulmonary function tests, and I'll talk about that in a little bit, so hold on to that. Lastly, just how would you treat this patient? Well, there's different types of bronchodilators that you learned in pharmacology. You can use beta agonists. You want a short-acting, like albuterol, and inhaled steroids you can use. So we'll go over that in a little bit. Before we go into diagnosis and treatment, I just want to touch on restrictive lung disease. So we already went over the wide variety of causes, but in general, this is an inability to bring air into the lungs. So like I said before, that's poor compliance. And you really need a good history, because there are just so many diseases that can cause restrictive lung symptoms. And how would you diagnose this? Well, like I said, it depends on the history and physical. You would do a chest x-ray, you could do a CAT scan, you would do pulmonary function tests, you can do a bronchoalveolar lavage, which can help determine if there's any cancers. It allows you to biopsy. And you can also do urinalysis, which seems a little weird in this lecture, but there's some of the diseases like Wegener's granulomatosis actually have both lung and kidney involvement. All right. So let's skip ahead. We already talked about the history and physical enough, so you can do a chest x-ray. That'll help you determine if there's a nodule or cancer or if there's a pneumonia. But the big thing we're going to focus on are the pulmonary function tests. And there's 2 tests you can do along with PFTs for the diagnosis of asthma. One is known as a bronchoprovocation test, also known as a methacholine test, and that forces the lungs to constrict. So if you have an asymptomatic patient, you can give methacholine and it'll simulate and stimulate the symptoms of asthma. So after you give that, then you can do PFTs and see if they in fact have asthma. In a normal person, there will be a small amount of symptoms, but not enough to diagnose asthma. And bronchodilator response, because like I said, asthma is reversible. If you give a patient who comes to the office or the ER a bronchodilator and then their PFTs are reversed and their symptoms are fixed, then you know that it's another way of helping in the diagnosis of asthma. You can do something called peak flow, which instead of doing all the pulmonary function tests, you can just measure how much expiration they're able to produce. You can also look at an arterial blood gas, which will allow you to kind of look at the metabolic status of the patient. You can look at the pH, are they acidotic or alkalotic? And the pH, you might remember, is based mostly on the carbon dioxide and the bicarbonate. So the more CO2 you have, the more acidotic you're going to be, and the bicarb acts as a base. So if you have decreased bicarb, then they're going to be acidotic. If they have a lot of it, then they're going to be alkalotic. So these change based on the internal environment of the patient. You also will check alpha-1 antitrypsin levels if you think that there's a family history or they're not a smoker and they have COPD type symptoms. And then you can do a CAT scan or an MRI if you want to get a better look at a possible lung nodule or cancer. So this is what spirometry looks like. Some of you may have experienced this if you have your own history of asthma. But there's a receptor connected to a computer. You can sometimes clip the nose. You have the patient inhale as much as possible and then exhale as much as possible. And they do that a few times until they're happy with the reading, and then you can evaluate that. So what does it look like when they're complete? I'm not going to spend a lot of time on this because Aditya talks about it in his, and you probably learned about it in respiratory physiology. But if you look starting here, this is tidal volume. So the patient breathes in and out normally when you're not thinking about it. When you're not thinking about breathing, that's your tidal volume. But if you go back, so they take a deep breath as much as they can, right? So when you add the inspiratory reserve volume, which is the extra inhalation, to their normal tidal volume inspiration, you get your inspiratory capacity. So from here to here. And then immediately after the deep breath in, they exhale as much as possible. So from top to bottom, from inhale to exhale, that's your vital capacity. That's the most amount of air that is can be transferred in and out of your lungs. If you look down here below this, you see RV. That's your residual volume. That's the amount of air in your lungs that you cannot expel no matter how hard you try. And then you have your total lung capacity. So these will change based on pathology of the lungs. Do you have an inability to breathe in, right? That would be a restrictive disease, so maybe it only goes to here or here. And they look different when you're talking about diseases, but for this graph, it would say go to here or here. And then for exhalation, if it's obstructive, you don't get as much out, right? So say it ended here, now you have this much air left in your lungs. So the residual volume increases. Over time, your total lung capacity will increase for obstructive disease because air is trapped. And total lung capacity would decrease if it's restrictive because you are not bringing in as much air as you would like. All right, so let's keep going. Another very important test for the diagnosis of obstructive diseases in particular is the forced expiratory volume in 1 second. So this is exactly what we just talked about. So what you do is that you inhale as much as possible, and then you breathe out. And in 1 second that you breathe out is known as the FEV1. Now, I couldn't find a picture that combined everything. So if you look over here, you can see the vital capacity. This is the rest of it, right? So after the FEV1, how much more are you able to expel? So let's move on to here and see how that affects your diagnosis. So for COPD in general, FEV1 is decreased, right? Because it's obstructive. So the amount that you breathe out in 1 second decreases. The total amount, the other picture just showed it as the vital capacity, but it's FVC for forced vital capacity. That is decreased also because the total amount, not just in 1 second, but your total amount of air exhaled is decreased. So what they do, this is the most important part, is they take the ratio of these and see what happens. So normal is about 80%, say. What happens to that ratio? Is it above 80? Is it staying at 80? Is it decreased? Is it below 70? In COPD, if you see that this ratio is decreased less than 70, then it's a COPD diagnosis. So that means that the FEV1 is decreased more than the FVC. So the amount that you can exhale in 1 second is decreased substantially. And then, like we talked about before, total lung capacity and the residual or reserve volume is increased because you have air trapping. On the other hand, with restrictive disease, even though we talked about how it's inhalation, you still have a decrease in the amount of air exhaled. However, in this case, now it's not the FEV1 that's decreased the most, it's your FVC, the total amount of air exhaled. So now when you look at the ratio, no longer is it below 70, it's actually normal, or it can be a little bit increased. So once again, that's the biggest indicator of obstructive versus restrictive lung disease, is the ratio of FEV1 to FVC less than 70, or is it normal or increased? And now, like we also talked about, the total lung capacity and the RV is decreased because of the difficulty inhaling. So now the question becomes, we know that COPD has these decreased FEV1, FVC, and the ratio is decreased as well. Excuse me, but how do you tell whether the patient has chronic bronchitis versus emphysema? Now, we went over the history and the physical, so maybe the patient's cyanotic and maybe they're obese, but in the real world, everything is not that cut and dry. So there's another test you can do to help differentiate the two of these. The first would be, or I should say, what you can do is called the DLCO, or the diffusion capacity of carbon monoxide. So really what this is getting at is the lung parenchyma destroyed in the alveoli? And with emphysema, like we talked about, because there is destruction of the alveoli from those proteases that kind of go unabated, the ability of carbon monoxide to diffuse is decreased, right? Because the alveoli are enlarged and destroyed. So it affects the ability of oxygen and carbon dioxide to cross those capillaries. So in chronic bronchitis, that does not happen, right? It's more a different part of the airway. So that the ability of carbon dioxide and oxygen to diffuse is normal. So the takeaway message is that for COPD, the ratio is decreased. Most of the PFTs are decreased, the FEV1 and the FVC. And then you want to look at the DLCO. Is it chronic bronchitis or emphysema? So you can also look at the flow volume loop, and this is all saying the same stuff over and over. So let's look at red, which is normal. So you start here, which is kind of weird, and as you go to the left, the lung volume increases. So you inhale, and you go this way because you're increasing your lung volume, and then you exhale as much as possible. This is the peak expiratory flow, and then it kind of slows down, right? So with obstructive, we said that the total lung capacity is increased. So that means even when you start, you're starting with an already increased total lung capacity, and then you exhale. So even if you don't want to focus on memorizing really the physiology, the nitty-gritty details, as long as you know that the lung capacity increases to the left, and that automatically means that obstructive lung disease has to be this curve here, as opposed to restrictive, in which the total lung capacity decreases. Okay, so there's also changes to the curve, right? But the big thing is, so if you want to look here, you can see that this is really concave if you're looking at it from up here, and that's a sign of obstructive lung disease as well. But as long as you remember the shift, the restrictive will never be over here. Okay. So you have a patient you think has asthma. What exactly do you do? So we already talked about this, right? The ratio is going to be low. Might not be below 70 because that's COPD. You're going to have a normal or slightly increased diffusion ability, so it's not decreased, so it's not emphysema. They're going to present with shortness of breath and chest tightness. So what would you do? Well, then you would perform spirometry, and if you diagnosed it, you can supply albuterol because that's a bronchodilator, right? It works within 30 seconds to a minute. And what you will see is that there's a reversibility and improvement in that forced expiratory volume in 1 second by at least 12%. So that's a very big hint that your patient has asthma. So what happens if your patient complains and says, "Doc, I have wheezing and chest tightness at night when I run, during the cold, whatever," but they're asymptomatic in the office? Well, you can give them a trial at home and say, "Let me know if that works," or you can do a bronchoprovocation test with the methacholine. So they're asymptomatic, so you're going to induce an asthma attack. It won't be life-threatening, but methacholine is an acetylcholine agonist, right? So that's going to cause bronchoconstriction, and that'll actually drop your FEV, the opposite of a bronchodilator, by at least 20%. So if you see a drop of at least 20%, that's another indication that your patient has asthma. In acute settings, say a patient comes in to the emergency department, you're not really going to sit down and do PFTs, right? Because they're probably going to be abnormal anyway. So what you do is a peak flow measurement. Not all ERs do this. Some will just say, okay, the patient's short of breath, so we'll start giving you oxygen and albuterol, yada, yada. But what you really should do is look at the peak flow measurement. So normal, it's not important for you guys to memorize the numbers, but if you look, normal is about 450 to 650. It's a little different for women because of lung size. But there's different degrees of an asthma attack. So is it mild, or is it moderate to severe, or really severe, right? So don't memorize the numbers, but just know that the peak flow will decrease as the severity increases. So there's something you may have learned in pharmacology about step-up treatment or step-down, but really the only thing they use is step-up. So what you have to know as a physician is when you ask about the history, what you're determining is how severe is your patient's asthma. If they have 2 or less times a week, it's mild intermittent. And this is long-term, so this is a little confusing. But what you're going to do is you're going to provide an albuterol inhaler as needed, PRN. So less than 2, just give them albuterol. Is it more than 2 times but less than every day of the week, so 3 to 6 times, now you're going to use albuterol plus a low-dose inhaled corticosteroid, and that's also going to be PRN. So there's combinations. One's called Duaneb, and that's a combination of, I believe, an albuterol and corticosteroid. Another if you go further down, now your patient's having daily symptoms, frequent exacerbations. So once you see daily, it's moderate. And now you're going to use the above treatment, but you're going to use it every day at a scheduled time, not just as needed. The other thing you can do is you can add some of the other things like cromolyn or one of the methylxanthines, theophylline, or anti-leukotriene, montelukast, or something like that. But honestly, those aren't used that often. The last thing is severe persistent, so this is continual symptoms. And now you're going to use a daily inhaled corticosteroid. It's high dose instead of low dose. The other thing is you're still going to have them on the albuterol, but you're probably going to start them on a long-acting beta agonist as well, like salmeterol. And you can also do systemic steroids now instead of a low dose. Well, you're going to add the high dose, but you can also add like a PO prednisone if it's that severe. But if you look up the side effects of taking a systemic steroid like prednisone, there's a lot of side effects, so you want to be really careful about that. What about the treatment of COPD? So there's only two things, excuse me, that you can do to treat or decrease the mortality of COPD. One is to give home oxygen. So you might see people walking around with a little oxygen tank, right? They probably have lung disease, obviously, and it's probably COPD. And they're carrying the oxygen tank around because that's the only thing that's decreasing their mortality, unfortunately. The other thing is smoking cessation. So just like asthma, you're going to use a short-acting beta agonist. You can use an anticholinergic along with that, like ipratropium or tiotropium. Ipratropium is short-acting, tiotropium is a longer-acting, kind of like albuterol, salmeterol. Inhaled corticosteroids, not as important in COPD as it is in asthma, just like anticholinergics are more useful in COPD than in asthma. Theophylline, there's a lot of side effects. I don't really use that anymore. Antibiotics can be used in acute exacerbations because of the risk of pneumonia. And you also want to make sure that they're vaccinated, right? Do they have their influenza vaccines, and do they have the strep pneumonia vaccine, also known as the pneumococcal? So I figured we could end with a few short little vignettes to help kind of hit some of this stuff home. The first one is a 15-year-old boy who complains of cough at night at least once a week. So he has moderate persistent asthma, and that's because his symptoms are occurring at night at least once a week. I should clarify. It's not once a day. It's once a night, or at night once a week. If it was once a week, then that would be mild intermittent. But you can see how much it changes based on the time of day. When it's at night, now he has moderate persistent. So now you're going to use a short-acting beta agonist, a low-dose steroid, and you can use a long-acting beta agonist. The next case is a 25-year-old female with asthma, complains of needing her rescue inhaler 3 times a week. So now it's not at night, it's during the day. It's more than 2 times, but not every day of the week. So she has a mild persistent. So you can use PRN, low-dose inhaled corticosteroid, plus albuterol. The next one is a 35-year-old patient with no smoking histories and PFTs showing obstructive pattern. He also has elevated liver enzymes like AST or ALT. In this case, it's a little tricky, alpha-1 antitrypsin deficiency. This disease commonly presents, I think it's 90% of patients with this disease have liver involvement as well. Next one, a 70-year-old man presents with a thin-looking appearance. He has pink skin, he's breathing through pursed lips, and has a pulse ox below 90, so this is going to be emphysema. So short-acting beta agonist, anticholinergic now, you want to make sure he's vaccinated, and because his pulse ox is below 88%, you want to use home O2. Last one, 55-year-old woman wakes up at night with a dry cough, works when she eats before falling asleep. So this is classic for acid reflux, also known as gastroesophageal reflux disease, or GERD. And as I mentioned earlier, the most common causes of nocturnal cough are asthma and acid reflux. So that was a lot in a short period of time, but I hope you begin to understand the process of taking a history and physical relating to lung disease, PFTs and how they relate to specific diseases. It seems like a lot, but when you really break it down, it just comes to that one ratio we talked about. Determine the severity of asthma based on how often they have symptoms during the day or at night, and then how you treat both an asthmatic and a COPDer. Thank you very much.